Medical TuneUp. Tune your knowledge to higher frequency.
Hello Divya, I am Dr. Sharath and I'll be taking your case today. Good morning, sir.
Good morning, Dr. Sharath. Present the case.
Miss Divya, 20-year-old girl from South Asia, presents with intermittent pain of the right hand for 6 weeks. She also complains of malaise, night sweats, weight loss, arthralgia and fatigue. She was diagnosed with pulmonary tuberculosis 2 years ago, which was treated with a full course of therapy for 6 months. Follow-up for an year afterwards showed no evidence of recurrence. On general examination, pallor is present, no cyanosis. In the right upper limb, radial and brachial pulses impalpable, confirmed by handheld Doppler. BP unable to record. Left upper limb, pulse 80 beats per minute, regular, high volume. Subclavian bruit is present. BP 140 by 90 mm of mercury. Left and right carotid pulse are normal. On systemic examination, lungs, trachea is slightly deviated to left side. Decreased breath sounds over the apex of the lung is heard. On CVS examination, no abnormalities found. Abdomen, no abnormalities found. CNS, no abnormalities found. On local examination, Raynaud's phenomenon is positive. Addison tests negative.
So in this patient, what is your interpretation?
Sir, she has presented with intermittent pain of the right hand. Examination of the affected limb shows all the peripheral pulses to be absent and the blood pressure to be unrecordable. We suggest that the pain is due to claudication, and the presence of subclavian bruit in the contralateral limb suggests a bilateral pathology.
What are the differential diagnoses for a pulseless upper limb?
In a patient of this age, the most likely cause for a pulseless upper limb is a large vessel arteriopathy, which may be non-inflammatory in origin or inflammatory in origin. Non-inflammatory causes like cervical rib, which may compress the subclavian artery, causing non-inflammatory arteriopathy, which may be bilateral. However, in this patient, systemic signs argue against this diagnosis, whereas the causes of inflammatory are Takayasu arteritis and giant cell arteritis are the most common large vessel vasculitis. However, the giant cell arteritis is a disease of elderly and is not encountered in patients less than 50 years of age. Conversely, Takayasu arteritis is a disease of the young age and is rather uncommon beyond the age of 40 years. Other differential diagnoses for large vessel vasculitis are syphilis, and rarely active tuberculosis may give rise to a large vessel vasculitis.
What's a provisional diagnosis?
Sir, Takayasu arteritis.
What are the investigations you would like to do?
So, I'd like to perform an ESR, chest X-ray and CT angiogram of upper limbs.
Don't you want to consider tuberculin test?
No sir, because the tuberculin test is of little use as it will be positive in patients with a history of tuberculosis.
So, what did your investigations show?
Sir, ESR is raised, that is 120 mm per 1/2. On chest X-ray, it shows fibrosis of the apex of the left lung. There is no cavitations or evidence of cervical rib. On CT angiogram, there is total occlusion of the right subclavian artery with rich network of collaterals. There is significant stenosis of the left subclavian artery. The aortic arch appears normal.
So what is your interpretation from this?
Based on the above finding and along with the clinical presentation, it is sufficient to confirm the diagnosis of Takayasu arteritis.
What is Takayasu arteritis?
It is a form of large vessel granulomatous vasculitis with massive intimal fibrosis and vascular narrowing, affecting often young or middle-aged women of Asia. Although its etiology is unknown, the condition is characterized by segmental and patchy granulomatous inflammation of the aorta and its major branches. This inflammation leads to arterial stenosis, thrombosis and aneurysms.
Is it important to rule out tuberculosis even if your diagnosis is Takayasu arteritis?
Yes sir. Reactivation is worth considering in this patient as constitutional symptoms and high ESR suggests of it. Additionally, a past infection with tuberculosis has been implicated in the pathogenesis of Takayasu arteritis. Even from the perspective of treatment too, it is essential to exclude reactivation of tuberculosis because High-dose steroid therapy, which is used in initial management of inflammatory vasculitis, leads to disasters if administered alone to such a patient.
So how do you treat Takayasu arthritis?
High-dose steroids are the mainstay of our treatment and should be commenced as soon as possible.
That was a good presentation, Dr. Sharad. Keep it up.
Thank you, sir.